Hello and welcome to today's webcast, What's New in Anticoagulation Therapy? I'm McKnight's editor Jim Berkland and I'll be your moderator today. I predicted from the start that this would be one of our most popular webinars ever, and while I don't have the final numbers, we know it's going to certainly be in the top tier. Anticoagulants are common, of course, in large sections of the adult population, and in long-term care, there's an even a bigger role. So there's no question there is a need and a benefit to using them. However, and that's a big however, at the same time, these blood thinners need very careful consideration. Look at any top 10 list of riskiest drug interactions and you'll find warfarin sprinkled throughout. Handle with care might as well be the sticker that applies here. So we're glad you're here today, and our outstanding speaker, Tim Ozer, is going to tell us some fantastic information about what's new and maybe some things that aren't entirely new, but definitely bear repeating. But first, we have some housekeeping matters to take care of. I'd like to note that today's slides will not be available for download, but they will be the basis for some great note-taking, so keep your pencil sharp. Now, if you think you're having audio problems with this broadcast, please first check the volume control on your machine. We found this is the most common cause of hearing problems on presentations like these. Similarly, we encourage you to keep just one browser window open to cut down on the risk of viewing problems. Now, we will have time for a Q&A session near the end of Tim's presentation, so if you have any questions, please feel free to tap them out and submit them directly to us at any time during this hour, starting now. Regarding CE, this educational offering has been reviewed by NAB. It has been approved for 1 clock hour. However, you need to stay tuned to this event for its entirety during its original broadcast in order to receive a certificate. A link to your certificate will be emailed to you. If you don't receive it by the end of the day, please check your spam folder. Now, please also be aware that NAB recently changed its process for obtaining CE credits. Since April 1st, all licensed long-term care administrators seeking CEs must provide their NAB CE registry ID number in their webinar registration form. Hopefully you've seen that already. McKnight's cannot verify or report attendance to the NAB CE registry without this information. Now, to create a CE registry account and ID number, please refer to the NAB Verify User Guide. For this and additional information regarding compliance with the new CE rules, please visit them at www.nabweb.org/CE registry. Now, we also like to note that this program is made possible by support from Omnicare. Please visit the fine folks there at www.omnicare.com. But remember, don't interrupt this webcast presentation if you would like to earn the CE credit. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access it again, or others can experience it for the first time by simply going to the registration page to enter this studio. The URL is mcknights.com/November13. Now, I'd like to tell you a little bit more about today's presenter. Tim Ozer is a 24-year veteran pharmacist now specializing in managing warfarin dosing. He has been a board-certified geriatric pharmacist since 2004. He started his career in an operational consulting role, primarily reviewing charts in long-term care facilities. Later, he moved into the formulary interchange where he helped with securing prior authorizations. For the last 8 years, he's been in his current role regarding warfarin dosing. Now, in addition to monitoring patients, he serves as a preceptor for Omnicare's Advanced Pharmacy Practical Experience Program, as well as the PGY-1 Community Pharmacy Program. Through the APPE program, he coaches 2 students each month who are learning about the long-term care business. Through the PGY-1 Community Pharmacy Program, he teaches and supervises 1 resident for the entire year. So far in his career, he has mentored and taught more than 200 students. And Tim, I can tell you that you have hundreds more students ready, willing, and able on the line today. And I guess it's safe to say that one really doesn't dare stop learning in this field, right?
Right on, Jim. Thanks for having me. I appreciate that. I'm really looking forward to going through this material, and I appreciate all who took the time today to getting on this call. I'll be talking about what's new in anticoagulation therapy, a hot topic since many changes, new therapies, and indications have been introduced in the last few years. I will provide an overview of the importance of understanding the safe and proper use of anticoagulants. Although the content isn't always simple, the objectives are. I'm going to overview the various oral anticoagulants, and we will pay specific attention to how we, as healthcare professionals, can help identify risk factors for bleeding, as well as look at clinical considerations that may guide therapy to mitigate the bleeding risk associated with their use. But let's start by discussing the risks of anticoagulants. Even though it may be obvious to us as experienced healthcare professionals how anticoagulants can cause harm and even death, the risk is even greater in the senior population that we serve. As you can see from this slide, anticoagulants are the most common drug class associated with adverse drug reactions that lead to emergency department visits and hospitalization after an emergency department visit. 1/3 of adverse events in hospitalized Medicare beneficiaries are believed to involve anticoagulants, and just a few years ago, an estimated 34,000 fatal, life-threatening, or serious adverse events involving warfarin happened in nursing homes each year. But the second to the last statistic on this slide is very important, because even though the adverse events of warfarin are common, 29% of overall warfarin-related adverse drug events and 57% of the most serious events are considered preventable. So, as we go through this presentation, think about where you might be able to further intervene or help with those you serve. Even more compelling, as depicted in the bar graph here, is that the medical literature showed that for those 70 years of age and older, which certainly describes the majority of patients we serve, anticoagulants were the #1 cause of adverse drug reactions in both the ambulatory and the hospital settings. So, with the risk of anticoagulants in mind, let's move into evaluating the proper use of oral anticoagulants. While our primary focus will be on the oral anticoagulants, this slide is meant to make sure that we all begin on the same page. When we discuss anticoagulants, we might put them into 3 or 4 categories. The heparins, which include not only unfractionated heparin, but also the low molecular weight heparins, the vitamin K antagonists, of which we only have one, warfarin, and then the newer direct oral anticoagulants, or they're also known as DOACs, which can be further broken down into direct thrombin inhibitors or factor Xa inhibitors. One of the first questions that has to be answered with regard to proper use of anticoagulants is what can you use them for? If an anticoagulant hasn't been approved by the Food and Drug Administration for a certain use, it typically isn't safe to use it that way. Notice first, only the oral anticoagulants are FDA approved for use in atrial fibrillation patients for prevention of stroke or other thromboembolic events, and specifically, looking at the newer anticoagulants, unlike warfarin, they are not approved for valvular atrial fibrillation, only non-valvular atrial fibrillation. Secondly, you will notice that the indications for newer agents vary such that while all can be used in one way or another for DVT treatment, most but not all of them can be used for DVT prevention. And we will see more about this as we go along. Now, allow me to add here that as of October of this year, rivaroxaban, Xarelto, has a new FDA indication. It specifically indicated lower dose, lower than for DVT treatment and prevention, as 2.5 milligram twice a day, along with aspirin 75 to 100 milligrams daily, used in conjunction to reduce the risk of major cardiovascular events such as MI or stroke in patients with chronic coronary artery disease or peripheral arterial disease. So my point here is, with this new indication, is that the documentation of the diagnosis of these medications are so important in assuring that the patient receives the right dose and right duration of therapy. And again, we will see more about this as we go along. But with warfarin in mind first, let's go a little deeper with identifying the various risks associated with this drug. We are all very familiar with the use of warfarin, but I think it is important to realize just why warfarin can be so dangerous. Beyond the rapid changes in their health status, we know that missing a dose or changing their diet or adding just one medication to a stable regimen can have dramatic consequences. In fact, with some interactions, the anticoagulant effects of warfarin can increase by over tenfold in a matter of a few doses or days. There are a wide range of doses available for warfarin, but for older residents, the initial dose of warfarin should generally be about 2 to 3 milligrams a day. This more conservative approach is because the elderly so often take other medications that may interact, and they often have other risk factors for bleeding. But every resident's dose must be individualized so that when a dosage adjustment is necessary, it is important to realize that changes up or down should generally not be greater than 10% from their current total weekly dose of warfarin. So for instance, with a low INR of, say, 1.7, a dosage increase of 10% in the weekly warfarin dose may be recommended, although some practitioners may alternatively consider an extra one-time dose of warfarin. There are only a few slides about warfarin interactions in this presentation, but this slide reminds us all why it is such an important topic. First, it is imperative that we recognize that many interactions with warfarin can cause an exponential increase in its anticoagulant effect, even after only a few doses. Secondly, we need to be aware that many residents already carry a high drug interaction burden. So in addition to their chronic medications, the addition of another interacting medication can be enough to disrupt the established balancing act. Thirdly, many are high-risk patients with multiple chronic disease states and commonly some degree of chronic kidney disease. Fourthly, with the availability of emergency drug supplies, sometimes new medications are given before the pharmacy can screen and warn about the risks. Because antibiotics are some of the more common medications started from emergency drug supplies, and because many of the top interactions with warfarin involve anti-infectives, Omnicare has provided a tool since 2008 related to this topic. You can see just the top portion of this two-page tool entitled the Antibiotics, Anti-infectives that Interact with Warfarin tool, which was most recently updated in December 2017. This tool in its entirety is available on OmniView, and the differing severities indicated in this tool align with the drug-drug interaction screening that takes place in our pharmacy dispensing systems and is used in the computer software that our consultant pharmacists use. Along with the tool I just showed you, Omnicare for several years has had an anticoagulation safety program and has gradually expanded over time. These 4 categories of antibiotics receive additional attention when prescribed with warfarin. With these particular antibiotics, all have the potential for increasing risk of bleeding. It is suggested that the prescriber consider doing a proactive 30% reduction in the warfarin dose, and more importantly, that they monitor an INR every 3 days while on these therapies with warfarin. Additionally, nursing and caregiver monitoring of the patients should be heightened in order to keep the patient safe during these times of greater risk. This slide is a quick summary of many, but obviously not all of the drugs that can significantly impact an individual's INR. On the left side, we see drugs like other anticoagulants or antiplatelets, NSAIDs like ibuprofen, amiodarone, and SSRIs like citalopram that can all increase someone's bleeding risk. And on the right side, you see drugs like carbamazepine or phenobarbital that can increase the metabolism of warfarin, thereby decreasing the benefit of warfarin and leading to a reduced INR. A common misconception related to warfarin that you may have heard before is that individuals who take warfarin should not eat green leafy vegetables. While it is true that the vitamin K content of green leafy vegetables is high and that this may reduce or counter the effects of warfarin, these foods do not need to be avoided, just simply monitored. It is important to try and maintain a consistent level of vitamin K in the diet to avoid fluctuations in response to warfarin. Example, don't binge on these vegetables one day and eat none of them the next. Because of the importance of considering the effects of food on an individual's INR, presented on this slide is part of a tool available through the manufacturer of Coumadin that helps you keep the amount of vitamin K in various foods in context. So with that brief discussion of warfarin, let's talk about why we might consider a newer direct oral anticoagulant, or DOAC, instead of a vitamin K antagonist. Because warfarin has been around so long, we certainly have more data in the elderly as well as in patients with severe kidney disease. Likewise, we have a reversal agent readily available, that is vitamin K. And then a few slides ago, I mentioned that warfarin, unlike the DOACs, can be used in valvular atrial fibrillation. But the need for DOACs becomes clearer as we recognize that they carry a reduced risk of intracranial hemorrhage compared to warfarin, and that is considered the most serious and terrifying event possible with anticoagulants. Also, the DOACs have fixed dosing. In other words, they only come in a few strengths, and the dosage is based upon various factors such as the reason for use and kidney function. Next, we see that the DOACs have fewer drug and drug-food interactions compared to warfarin. But let me be clear that some think that they have a more complex list of interactions, although a much shorter list. Finally, unlike warfarin that requires continual monitoring of the patient's anticoagulation status, if the patient is compliant with a DOAC, they are considered therapeutically anticoagulated. But you will notice under the scale this quote from a 2015 Lancet article which summarized the need for DOACs by saying that they are at least as effective as warfarin at preventing stroke, with advantages of less serious bleeding except for GI bleeding, which occurs 25% more often than with warfarin. The next 2 slides are intended to provide an overview of administration considerations for the proper use of DOACs. And this first one addresses the idea of frequency of administration. When Pradaxa and Xarelto were first approved, and the only new drugs on the market, it was easier to describe the administration of these drugs. But as new drugs and new indications have been added to these drugs, you will see that usually rivaroxaban, Xarelto, is once daily. But initially for the treatment of DVT, rivaroxaban is given twice daily. Likewise, we used to think about dabigatran, Pradaxa, as being only twice daily anticoagulant. But for its newest indication, DVT Prophylaxis after hip replacement, it is given only once daily. This makes it imperative that we know why the drug is being used so that we can determine if they are being dosed correctly. Beyond the frequency of administration, there are also significant variations with these drugs in regards to whether or not they need to be given with food, and some can be crushed and others cannot. As you will see on this slide, whether or not you need to give a DOAC with food is again dependent upon why you are using the drug, except with Eliquis and Savesa, which can always be given with or without food, and Bavixa, which must always be given at the same time of day with food. Also, I would remind everyone that dabigatran, Pradaxa, cannot be crushed or opened, as that actually significantly increases the risk of bleeding. So for individuals with an enteral tube, dabigatran is likely not the best choice. We won't go into depth on them, but the next several slides are meant to provide the general dosing guidance for the DOACs for their various uses, and you'll see that the dosing also depends heavily upon the individual's kidney function. In the chart on this slide, you will see that for creatinine clearance greater than 30 mils per minute, the typical dose of dabigatran, 150 milligram twice daily, is recommended. However, the FDA and manufacturer suggest a lower dose of 75 milligram twice daily for a creatinine clearance between 15 and 30 mils per minute, and no dosing guidance is available for less than 15 mils per minute. But it is important to realize, as the footnotes show, and which you cannot see, that number one, additional dosing adjustments may be necessary with particular drug-drug interaction combinations, and secondly, that the FDA approved the dose of 75 milligram twice daily without any human data, so caution is advised. Based upon this alone, prescribing dabigatran to a patient with a creatinine clearance between 15 and 30 mils per minute should probably only be done when the benefit clearly outweighs the risk of alternative therapies. For rivaroxaban, the dosage adjustment from 20 milligram down to 15 milligram occurs with a creatinine clearance less than 50 mils per minute. And unlike the twice daily dabigatran, once daily rivaroxaban for the treatment of AFib is intended to be given with the evening meal. For apixaban, the determination of the appropriate dose is not really determined by creatinine clearance, but rather whether or not a patient meets two or more of the following criteria: age greater than or equal to 80, weight less than or equal to 60 kilograms, and or serum creatinine greater than or equal to 1.5 milligrams per deciliter. If either two or all of these three criteria are true, the patient's dose should be reduced from the usual 5 milligram twice daily to the adjusted dose of 2.5 milligram twice daily. But it should also be pointed out that apixaban was not formally studied in patients with a creatinine clearance less than 25 mils per minute, so use in such patients is probably best avoided. And with Savesa, I want to point out that uniquely, Savesa must be avoided with not only poor kidney function, but also with very good kidney function. Also, the usual 60 milligram dose of Savesa is reduced in half for a creatinine clearance of 30 to 50 mils per minute. And while FDA-approved dosing exists for 15 to 30 mils per minute, it was not thoroughly studied in those with a creatinine clearance less than 30 mils per minute. This second dosing slide addresses the treatment of deep vein thrombosis or pulmonary embolism. While dabigatran, Pradaxa, was originally approved without this indication, all of the DOACs except the newest one, Betrixaban, Bavixa, now can be used for active treatment of DVT or PE. However, I would point out, as you can see with the second footnote, which, sorry, you probably can't see it, but that both Pradaxa and Savesa are only approved for this indication after the patient has already received 5 to 10 days of a parenteral anticoagulant such as enoxaparin. The third indication we see here is DVT prophylaxis. And specifically, we are talking about DVT prophylaxis after knee or hip replacement. Currently, only Xarelto, Rivaroxaban, and Eliquis, Apixaban, are approved for this indication following both knee and hip replacement. But Pradaxa, dabigatran, more recently gained approval for use following hip replacement surgery. And as you will note here, this is the only indication that uses a 110 milligram dose, and it is given as 1 capsule on day 1 and 2 capsules thereafter. You also see from the footnote, sorry about the footnote being so small, on the Xarelto 10 milligram, that the duration of therapy ranges from 12 days following knee replacement to 28 to 35 days with hip replacement. And while we just talked about VTE prophylaxis on the last slide, this slide highlights the newest direct oral anticoagulant, Betrixaban, or Bavixa, which has a unique FDA-approved indication. That is VTE prophylaxis in adult patients hospitalized for an acute medical illness who are at risk for thromboembolic complications due to moderate or severe restricted mobility and other risk factors for VTE. Now, I would point out that while the first dose of this drug, which is higher, should always be in the hospital setting, because the recommendation duration of treatment is 35 to 42 days, it will be seen prescribed for those patients who transfer to nursing homes. And as you can see, for those with an estimated creatinine clearance between 15 and less than 30 mils per minute, half of the standard dose is used. The final indication I want to discuss is what is referred to as reduction in risk of recurrence of DVT and or PE, which is typically following 6 months of treatment. You will note that neither dabigatran, Pradaxa, nor Rivaroxaban, Xarelto, are approved for use with a creatinine clearance less than 30 mils per minute. I've mentioned it a few times, but in addition to the FDA-approved dosing guidance, kidney function and anticoagulants was discussed within the 2015 Beers criteria. Within those criteria, they newly included a table related to non-antibiotics and the need to consider dosage adjustments based on renal function. That guidance is summarized on this slide, but I would again point out that while the FDA-approved labeling for many of these drugs discusses their use at lower kidney function, the Beers criteria took into account the limitations and exclusion criteria used in the clinical trials used for their approval. For instance, instead of supporting the FDA-approved dosing down to 15 mils per minute for dabigatran, edoxaban, and Rivaroxaban, the Beers criteria specifically suggest avoiding them with a creatinine clearance less than 30 mils per minute. And while the FDA-approved labeling for apixaban looks at specific patient characteristics such as serum creatinine, the Beers criteria suggest apixaban should be avoided with a creatinine clearance less than 25 mils per minute. Quickly, let's talk about laboratory monitoring for these drugs. Although many may say that one advantage of the newer DOACs is that they don't require laboratory monitoring, that actually isn't true. All anticoagulants have some degree of necessary lab monitoring, which is shown here on this slide. The difference is that warfarin has to have monitoring of the patient's anticoagulant status, while the DOACs do not. But both warfarin and the DOACs require monitoring of a CBC at baseline and at least annually thereafter, and a serum creatinine at least every 6 months. And since we keep mentioning renal function, let me take this time to emphasize the need for clinicians to calculate creatinine clearance when looking at the doses of these drugs. Since so many of these anticoagulants have dosing guidance or limitations of use based upon the patient's kidney function, creatinine clearance has to be considered. To that end, let me share with you a few places where creatinine clearance can be calculated as long as you have the individual's age, gender, height, weight, and most recent serum creatinine value. Various websites have calculators for estimating creatinine clearance, but it is important to recognize that some do not necessarily take into account body mass and whether or not that the individual is underweight or overweight. Beyond the great importance of considering renal function, another topic of great importance when determining the proper use of DOACs are drug interactions. This slide is intended to give a more global overview of the drug interactions. We won't get into the specifics as they move beyond just the cytochrome P450 isoenzyme interactions that we see with warfarin to also include a less familiar area of P-glycoprotein interactions. But as you can see, the DOACs do have drug interactions, just not as many as warfarin. But if your pharmacist indicates a potential interaction with a DOAC, don't ignore it. So with all of that background on the anticoagulants, let's move to identifying and mitigating risk factors involved with bleeding. Of course, we all know that the greatest risk associated with anticoagulants involves the risk of bleeding. So I begin this section with a slide that shows the common signs and symptoms of serious bleeding. Hopefully, you are familiar with each of these. But I would also suggest that you also instruct all caregivers of these signs and symptoms so that they can be alert and inform you promptly of serious bleeding if serious bleeding should occur. This slide cannot hold all of the risk factors for bleeding associated with anticoagulants and antiplatelets, but the most common are shown here. The first one, which we always speak about in our line of business, is advancing age. But we must realize that in addition to age being a risk factor for bleeding, it is also a significant risk factor for the very events we are using anticoagulants and antiplatelets to treat. So age is both a risk factor for bleeding and a risk factor for thromboembolic events. But in addition to advancing age and kidney or liver disease, other disease states and alcohol intake can also play a factor. With all of the antithrombotics, there are some other medications that specifically increase that we in Omnicare call the bleeding burden. And those include other anticoagulants or antiplatelet drugs, non-steroidal anti-inflammatory drugs such as ibuprofen, oral corticosteroids such as prednisone, and also antidepressants that specifically affect serotonin, such as sertraline or venlafaxine. But in addition to the risk factors in the center, which are all common, some other important risk factors we need to be aware of are those along each side, such as anemia or malignancy, history of stroke or TIA, and frequent falls. Beyond the risk factors we have just discussed, let me quickly summarize some of the inherent risks with these anticoagulants. This slide quickly summarizes the boxed warnings for anticoagulants. As you know, boxed warnings are the strongest warnings the FDA can require for medication, so it is very important that you are familiar with these. While dabigatran originally did not have a boxed warning when it was initially approved, it should be realized that all anticoagulants, except for unfractionated heparin, now have box warnings in their FDA-approved labeling. Warfarin's box warning highlights the general bleeding risk associated with its use, which we have already talked about. But that doesn't mean that bleeding isn't a concern for all of these drugs. The low molecular weight heparins and the direct oral anticoagulants also have box warnings discussing the risk of spinal epidural hematoma, which I won't elaborate on. Thirdly, all of the DOACs, except the newest, Betrixaban, because of their short half-lives, have a box warning related to early or premature discontinuation of use in the absence of adequate anticoagulation. Stopping these drugs too soon or even running out of the medication for a dose or two can put a potential at grave risk of a thrombotic event. So please, do what you can to encourage perfect adherence to these drugs. And if a patient cannot be very adherent, warfarin is likely a safer option. Finally, the last column of this chart shows a unique boxed warning that applies to Savesa for use in AFib. Because the efficacy of the drug is significantly reduced in patients with very good kidney function, use of Savesa should be avoided in patients with a creatinine clearance greater than 95 mils per minute. For the next few slides, I want to talk about assessing the risk. And this first slide uses the mnemonic ABCDE to remind us of clinical considerations when you select an appropriate anticoagulant. A stands for abnormally low weight, which alludes to the dosage adjustments necessary for apixaban and edoxaban. B draws our attention again to the bleeding risk with these drugs, but reminds us that this is especially important to consider in those with a history of bleeding. Particularly, dabigatran has the highest risk of GI bleeding among the DOACs. But again, the DOACs have a lower risk of intracranial bleeding compared to warfarin. C stands for creatinine clearance, so again, I urge you to consider when you should be calculating it. D, again, reminds us of the different drug interactions that exist. And of course, E reminds us of the greater risk that exists for our elderly patients. But beyond that mnemonic, to avoid both underuse as well as inappropriate use of anticoagulants in stroke prevention, the CHADS-VASc scoring system was developed. As a reminder, the CHADS-VASc scoring system is a maximum 9-point scoring system that looks at the most relevant risk factors for stroke and gives higher weighting to both age greater than or equal to 75, as well as history of stroke, TIA, or another thromboembolic event. Guidelines, especially for AFib, suggest that with a CHADS-VASc score of 1, treatment with either an anticoagulant or an antiplatelet should be considered, with preference for an anticoagulant. But with a CHADS-VASc score of 2 or more, anticoagulant therapy should certainly be considered unless there are specific clinical reasons to avoid such treatment. Only with a CHA2DS2-VASc score of 0 do we consider omitting antithrombotic therapy in patients with AFib, and yet a lot of our patients remain untreated. On the other side of the coin, we have the HAS-BLED assessment, which has a maximum score of 8 and helps us determine who is at the greatest risk of bleeding with the use of anticoagulant therapy. A HAS-BLED score of 3 or more is considered high risk. So if a patient has a score of 3 or more, you might need to consider not using an anticoagulant. Or, more appropriately, if their score is high because of a modifiable risk factor such as uncontrolled high blood pressure or use of an NSAID or antiplatelet, focus your attention on changing what you can and thereby decreasing the risk of bleeding. In spite of our best efforts, bleeding sometimes occurs. And so this slide is meant to remind us of certain actions we can take during those bleeding episodes. First and foremost, we must always contact the prescriber immediately if unusual bleeding is suspected. In regards to a patient on warfarin, prescribers may consider withholding a dose and or closely monitoring an INR, perhaps even daily until things get back to the desired range. But even though it has been a few years since the guidelines have changed, I would remind everyone that in the absence of bleeding, oral vitamin K is now only recommended with an INR greater than 10. And in the event of major bleeding, the patient should be promptly transferred to the hospital setting where they can receive IV vitamin K, factor 4, and fresh frozen plasma as necessary. Until more recently, there were no antidotes or reversal agents for the DOACs. But in October 2015, the FDA-Approved Praxbind, idarosuzumab, for use in the event of life-threatening or uncontrolled bleeding due to Pradaxa. Typically, because of its high cost and storage requirements, Praxbind will also require a transfer to the hospital setting. And while additional reversal agents are currently undergoing clinical testing, Xarelto, Eliquis, and Savaysa do not have a specific treatment regimen. In all cases, discontinuation of any medication that may be contributing to bleeding should be strongly considered, and the patient's bleeding should be managed as possible while you provide supportive care. So as explained, as of October 2015, we have the first reversal agent or sequestration agent for a DOAC, specifically Praxbind, idarosuzumab, which can only be used for reversing the effects of dabigatran. The other two agents shown on this slide are both investigational, but in all three cases, these drugs should only be considered for use when there is life-threatening or uncontrolled bleeding. These are not agents that are going to be kept in a facility's emergency box anytime soon. Each of these agents are very expensive and require transfer to the hospital setting. I would point out that while andexanet alpha is being developed for reversing the effects of factor 10A inhibitors and low molecular weight heparins, there's also interest in siraparintag, which may bind all of the DOACs, as well as low molecular weight heparins and fondaparinux. So this slide identifies situations of high potential bleeding risk. These occur more often than we think. Just in my warfarin dosing services, these situations are prevalent. For example, firstly, the use of 2 or more anticoagulants, except for appropriate bridge therapy. Secondly, a prolonged use of bridge or combination therapy. Thirdly, combinations of anticoagulants with 1 or more antiplatelets, example, aspirin, Plavix, an NSAID or prednisone. Fourthly, known drug interactions such as using warfarin and amiodarone, which of course amiodarone is commonly used for arrhythmia treatment. And lastly, the use of anticoagulants or antiplatelets with abnormal labs, such as an INR greater than 4, platelets that are less than 50,000, and hemoglobin less than 10 grams per deciliter. So again, it's important to identify these risks and monitor the patient closely for potential bleeding episodes. Beyond being aware of high-risk scenarios, this and the next slide both show us some strategies for improving the safe use of anticoagulants. These include close monitoring for a change in an individual's health or drug regimen, as well as being aware about procedures or duplicate therapies or drug interactions that increase risk. Also, when appropriate, lab monitoring may help raise awareness of the level of risk. Additionally, as we have talked about with the dosing of DOACs, we need to know the diagnosis for use, as this can determine the proper dosing and duration of therapy. With regard to warfarin, routine INR monitoring is essential, and as we have discussed with DOACs, routine monitoring of both a CBC as well as renal function is imperative. When possible, a reversal agent, such as vitamin K, should be readily available. And with the DOACs, a clear understanding of when to transfer the patient to the hospital is important. And finally, as shown on this slide, the use of gastroprotection, for example, a PPI, should be considered for all at-risk patients. Now, as I conclude, let me quickly share with you some important reminders. First, with the increasing number of anticoagulants available, we have to remember that the benefits as well as the risks of anticoagulants are significant. Secondly, I hope you have been reminded that the older persons with complex underlying conditions are at risk for bleeding, and in fact, the burden and risk are exponentially higher for seniors. Thirdly, it is essential that we take the time to consider the benefits and risks of individual or combination therapy. And finally, every day you need to remind yourself that we are all accountable for reducing the anticoagulation burden and risk of bleeding in those we serve. And with that, I'd like to open it up if anybody has any questions.
Well, Tim, first I want to jump in and say thank you very much for an incredible presentation. I mean, this really took things, broke them down, gave some great examples, gave some great detail, and we're seeing that already. And I also want to remind listeners that you can send Tim your questions right now. Just type them out, and we'll see them on our end, and we'll ask. We have a few in. We're going to get to as many as we can. If we don't get to your question in the real time now, we'll try to get you an answer afterwards as well. So if you get a sip of water there, catch your breath. Like I said, that was quite a loaded presentation, Tim. We'll go to our first question here. And Michael has a question that you might anticipate. Is Eliquis generally accepted to be a good alternative to warfarin?
Yes, Jim. Eliquis can be an alternative to warfarin. It's actually used quite often. It's probably one of the most widely used ones, but the CHEST guidelines and the indications are all there. But again, you have to be careful with it being used with the atrial fibrillation patients, whether it's is it valvular or is it non-valvular? It just wasn't, the Eliquis and all the DOACs were just not tested with the valvular AFib patients. So again, just be cognizant of that.
Okay, very good. Giles asks, if a patient has been a successful long-term user of warfarin without complications and has a protein 5 deficiency, protein S, my eyes are jumping around here, should they be transitioned to a DOAC?
Wow, that's a good question. I really don't have the answer for that one. I do know that if somebody is stable on warfarin and they're consistent with their medications, stick with it, that they're not labile. But with the deficiency of a protein S, I'm really not sure on that. I'd have to get back with you on that.
Okay, very good. Barbara asks, some of the symptoms may not flag for staff. Do you have suggestions to raise awareness?
Okay.
I'm not exactly sure that's the question verbatim, what she's referring to.
Yeah, I'm really not sure of flagging for staff. I hope this webinar has increased the awareness of when you're passing or these medications, warfarin, the DOACs. It's very important to keep a close monitoring of your patient because there's always that risk of bleeding. And with warfarin, you want to be looking at the anticoagulation status. How's the INR been with this patient since I'm administering warfarin? And then, of course, with the DOACs, you have to make sure that the patient is consistently taking those meds or consistently on a day-to-day basis, or that leaves them at risk of clotting. So clotting and bleeding risks here associated with these medications. So it's a balancing act.
Right, and I think what she might have been getting at too. So we'll get this a little bit circle around is that some of these signs, that her staff may not recognize. So how can she raise awareness for her staff to be on the lookout?
I see. Okay, so some of the things you need to look for is the patient confused? Is the patient having some mental status changes? Because that does go along with a potential bleeding issue or even a clot issue. Are they having some, nose bleeding, or you see some slight bleeding? So it's always just to be aware of some of those signs and symptoms, and make that nurse aware.
All right, very good. Danielle has a comment and question. It says, hello, I heard that Praxbind is not available at most hospitals. Do you know of any patients who receive this drug in a hospital setting?
No, I have not.
Okay.
Sorry.
Well, that's the word is out there is proper on that too as well then. So now we have one good from Jim. Is in your practice of dosing warfarin, what is the most significant drug interaction you see?
By far, Jim, I see the most significant is diflucan, fluconazole. Probably secondly, then Bactrim, sulfamethoxazole, trimethoprim, and then maybe thirdly Cipro. Those are just medications that are used so widely in our senior population, and because they have such a delayed effect, they're kind of tricky with warfarin. When to decrease the dose of warfarin and then when to come back and increase that dose once they're finished with those medications.
Okay, and Helen asks, why does Xarelto have indications to take with food and then another indication for with or without food?
Yeah, that's a good question. It was tough for me to understand that. It's really based on indication and tablet strength. So in the studies, the prophylactic dose of which is Xarelto 10 milligrams, the oral bioavailability was unaffected by food. And then in the studies, they also found that the higher dose, the 15 and the 20 milligram that is used for treatment in AFib, the absolute bioavailability during the fasting state was not as good as with the co-administration with food. So hence those specific instructions.
All right, very good. And now Marty asks, can you touch on why Savesa needs to be avoided in patients with very good kidney function?
Okay. Great question. I do know that in the clinical trials, it was an ENGAGE trial, AF trial, that the efficacy of Savesa was reduced and an increased rate of ischemic stroke compared to patients treated with warfarin occurred. I'm not sure exactly why, but that's what the clinical trials tested out to be. So there's an increased rate of ischemic stroke in good clinical or good kidney function with the use of Savesa.
Okay, very good. Now here's the toughest question, and we have many more questions. Thank you, everybody, we'll try to get to you as well, but we also have a couple final here. The toughest one is that I'm going to ask you is, if you want the listeners to come away from this presentation with one thing, one big takeaway, what would you say it would be?
I think the biggest thing is with our senior population, and it's of course it's growing older and older every day. It is so important that we monitor these patients and be an advocate to monitor not only their bleeding risk, but also their clotting risk, so a risk of stroke. Our senior population is so frail that these medications can cause harm. So it's very important that if you do not know, always consult, a nurse or a nurse practitioner or a pharmacist on, whether this is the appropriate dose of these medications. So I hope that you took away something from this, and I appreciate all that were on this, and hope to talk to you soon.
Well, I can guarantee you a lot of people have taken a lot from this, Tim. There's no question. And we all want to hope that you've enjoyed today's webcast. The slides are not available on this, but I do want to point out the session will be available shortly at mcknights.com/November13webinar. mcknights.com/November13webinar. Or you can go through your normal registration link at the events page to see it again, or someone to see it for the first time, and just click through on that. So we want to give our special thanks to Tim Ozer for an outstanding look at the sensitive issue of anticoagulant use. We also like to thank our session sponsor, Omnicare. Check it out at omnicare.com. And, of course, we want to thank you, our listeners. You've been a big part of the success today. You've provided many outstanding questions, and we look forward to seeing you again at future webcasts. And this is just a reminder that you can keep up to date on all of our webinars and special events by checking the Events tab at mcknights.com. Once again, thank you for tuning in. This is Jim Berkland for McKnight's, wishing you a good week.